Councilmember Jennifer Gamble. I'm the Vice Chair of Budget and Finance. Our wonderful Chair of Councilmember Kevin Roden is at home recovering from strep throat. So he sends his regards that he's not able to be here today, but he is watching at home. So thank you all for being here, and we will get started with the Hospital Authority. And we have with us Dr. Webb, and I'll let you get started and invite and introduce those here with you. Let me put on your mic. Let's see.
Am I mic'd up?
Is it, no?
Testing,
Okay,
testing.
there we go.
Okay. Well, thank you, Council Lady, and it is indeed a pleasure to be here. Appreciate the opportunity to come and present before you. This is the Hospital Authority, Nashville General Hospital Authority fiscal year 2024 budget. I am going to, I've got Chief Financial Officer here, Bruce Narramore, who will be taking over momentarily to walk you through the subsequent slides. I just want to start by indicating what our mission is. This is cited before each board meeting as well and posted throughout the hospital to improve the health and wellness of Nashville by providing equitable access to coordinated patient-centered care, supporting tomorrow's caregivers and translating science into clinical practice. Our vision is to be a leader in exceptional community health care and serving Nashville one neighbor at a time. I don't have to tell many of you about what's on this slide. Most of you already know it. We've been around since 1890. In 1963, the charter was created that moved to the Davidson County Metro Nashville undersite. And we're still licensed for 150 beds. We're operating 114 staffed. And you can see our number of employees there. And that plus is probably more relevant now. Active medical staff, and we are governed by Metropolitan Hospital Authority here in Davidson County, and we serve under the leadership of an 11-member board, which is selected by the mayor and ratified by the council. We are the primary teaching hospital for Meharry Medical College, and we have a number of clinics, specialty clinics, and primary care clinics, over 20, that service the needs of our ambulatory population. And at that point, actually, I am going to turn it over to our Chief Financial Officer, Mr. Bruce Narramore.
Check to see if I'm mic'd.
Oh, let's see.
Okay. So good afternoon. This is just a quick view of our 2023 budget, that we're still in that budget year, of course, and what our current actual and projected looks like compared to that budget. Just rough numbers. Our collected revenues are about $2.5 million shy of what the budget was, but thankfully there were some ARP funds that came to the hospital this year that are non-recurring, but certainly much appreciated. You can see the state staffing assistance down at the bottom in the red, $3.0 million, which is not going to be recurring next year because those ARP funds with the state have been exhausted, but they definitely helped us this year. So all in, you can see that the budget numbers were relatively close. Our expenses were budgeted to be 127. They're on pace for about 131 million for this year, a little bit higher than we had anticipated, and we're going to talk about some of those in a minute. So this is the 2024 budget, and so on the left side you have the actual and projected that we just looked at previously, and then what our 24 budget is shaping up to be. Our collections from patient efforts, 54 million going up almost 5 million to 58.9. That government funding is going to drop because of the non-recurring funds by about 3.4 million. And so all in, you can see the hospital generating other government funding is about just shy of 1.5 million increase over the current year that we're in. And then we have the subsidy. The request that we made to the administration was actually $60.2 million. The administration came back with a recommendation for 57.8, which is what's reflected in here. And so with that 57.8 subsidy, our budget for 2024 shows total revenues of 138.7, and right now we have an expense line that shows $139 million of expenses, a slight deficit, but we will figure that out before we get through the end of the fiscal year. And then this is just a brief review on what of the subsidy that is given to the hospital annually, what portion of it is actually available to provide patient care. And there's about $10.1 million that we use in other arenas, $4 million to lease the building that we're currently in, a little over $1 million annually to lease the parking garage or part of the parking garage. Then we have the intergovernment transfer that Metro makes in July to draw down roughly $7 million of federal money through the state. That program's been in place for about 11 years. We never know exactly what that number will be, but that's our estimate for 2024. And then we are charged in our subsidy for the $2.4 million annually for the legacy costs of the Bordeaux and Knowles facilities. So after those reductions, we have about 47.6 of that 57 available to support patient care. And then next is just, I know we have council people that have been here for the duration. Dr. Webb has been here for the duration, but we do like to just give a brief history of back in November of 2017 when 3 mayors ago, I guess, former Mayor Barry actually announced plans to close inpatient care at the hospital and transfer the Meharry residency programs outside of the hospital. It caused a calamity in terms of physicians departing the Meharry faculty plan. Meharry had to then go in also and make a lot of changes. They discontinued the cardiology contract that had been long-standing with Vanderbilt for cardiology, and we only had 30 days notice to pick that up to ensure that we continued cardiology coverage. We picked it up back in 2018 late, and we continue to carry that contract forward. And then this year in April, just a month ago, Meharry has been making some changes to their faculty, their practice plan, and they've determined that they were going to discontinue hematology oncology services, and Dr. Webb and the hospital stepped in to take on 2 providers from Meharry so that we can continue our cancer program. We also have added a second oncologist as well, not from Meharry. But we have an 82-year-old cancer program. It has been accredited by the American College of Surgeons Commission on Cancer. I think we're the second oldest one in Nashville, so it's something to be proud of. We didn't think it was time for that to sunset. So we're picking that up as well this year. It's in the budget. And this is just, as I talked about, you know, when the announcement was made to close inpatient services, these are basically the providers that were attached to the Meharry medical entity that over all these last 5 years, the hospital has actually taken on the salaries and support. And this is just the actual salaries for those providers. And you can see it's a big increase from 2018. It's about an $8.7 million annual. And we do collect professional fees. I don't want to say that we don't. We do, but that is a significant investment that was made by the hospital and this council and, frankly, the city of Nashville to keep these services intact. And this is just a year-over-year view of the subsidy. Many of you may recall that in 2018, with that closure announcement, there was a supplemental appropriation that was given to the hospital to keep it operating. And so in 2018, the subsidy was $52 million. We dropped it to 46, then 43, steady for 2 years. Of course, we had COVID. basically hit us in the middle of that FY21 number, which pushed our numbers, our expense numbers up considerably, 49.6, then to 54 in the current year, and then the recommended from the mayor's office for this time is 57.8. And I just note at the bottom there, that note is that over 7 years, that means it's only averaged a 1.9% increase, which for a hospital is pretty good, I just say. This is capital, and I will say that we were extremely excited when we learned that we had been recommended for $7.3 million of capital. So wherever that blessing came from, it is extremely well appreciated by the hospital. Our staff is excited. It's like, you know, we haven't gotten $7.3 million of capital in 6 years. So to get it in this year, and I know it's contingent on the surplus that we believe is going to be present at the close of the fiscal year, but we have so many needs in the hospital, and you can see our average age of plant is 19, which typical standard A Moody's is 11. So we're way older than the traditional hospital in terms of our equipment. We make it work. We do make it work, but it takes a lot, and it's a lot on our staff. This is the capital request that we had for 2023. I think we ended up getting about $1 million, and so I'll just say there are a couple of those that are highlighted in yellow. We had to replace our pharmacy cabinets, so that $1.5 million, we had to go into an operational lease, and it's going to cost us on our operating expenses about $330,000 a year. Similar with our space lab monitors that we had to replace, much lighter expense, but it's an operating expense that we didn't have previously. And then we just, we're in the process of updating our data center, which is actually in the Metro data center here, but the iron is actually ours, and that's almost $1.1 million of capital. We had to do it because our servers were out of date, and we couldn't update many of our clinical platforms without it. So, you know, without access to capital and 4% money, the timing was just always difficult. We had to enter into a lease for that. It hasn't started yet. There's a possibility the timing could work out, and we could use some of that $7.3 million to avoid the operating expenses that would be incurred there. And these are those just in simple terms. The Pyxis, the pharmacy cabinets, added about $320,000 a year to our operating. We have a washer sterilizer for our OR and endoscopy areas that is in process right now. The construction hasn't started, but right now that looks like it's going to add about $85,000 operating costs. And then, like I said, that data center in the Metro data center, that's about $335,000 annually. And for some of you may know that we had a security incident in the spring of 22 that put the hospital, basically our clinical system, down for about 40 days and caused a lot of billing disruptions for us and for Meharry. And it was because of those very old servers that someone bounced in. It wasn't a ransomware. It was just an effort to take over our CPUs in the servers and use them for Bitcoin mining, which is a common, yeah. So unfortunately, and it hurt us, it hurt Meharry's billing, it hurt everybody because everything had to be held up. We had to make sure that the environment was safe before we turned everything back on. So it was a lesson that we learned. The other, I'll just say, I know the $7.3 million is much appreciated. We have an ancient nurse call system. It works, and our telemetry and monitoring systems are really at end of life. So those will be two high priorities, along with a 14-year-old cath lab that we need to update. So those are three first candidates off the list that we'll be looking for with the 7.3. And that's the request that we made that was granted. Thanks to everyone for that. Very much appreciated. And then these are just a few little backstories. We've had clean audits every year since 18 through 22. Our job is to care for the most fragile And our business plan is to keep expanding services to our insured patients so that we can offset the cost of the patients that we take care of that don't have the ability to pay. And that's what we're trying to do with our off-site clinics, is attracting insured patients to those to offset the cost of care for uninsureds. And this is Dr. Webb's slide. He loves this slide. Because I don't have anything to do with any of these.
And if you're not in healthcare, it probably doesn't mean a thing to you. But these are just some of the recognitions, accreditation, being recognized, National Committee for Quality Assurance for our clinical ambulatory services, of course, Joint Commission, Bruce mentioned our cancer, our Commission on Cancer accredited cancer program, the second oldest in the region, and for that many years, it's been accredited by the Commission's general surgeons under this program. As a matter of fact, it receives high praise year in, year out. Well, it's actually every 3 years, so triennially. I won't go through all of these, but these are just some of the things that we're doing to make sure that we're practicing evidence-based healthcare at Nashville General, and the outcomes continue to illustrate that. So I will move on to the next slide.
It's interesting that he didn't talk about his one in the right corner there, because his drive is Malcolm Baldridge level. We're level 3, working on level 4. That's not just for hospitals, that's for a lot of engineering entities and so forth. So we've achieved level 3. We went 2, then 3, and now 4 is the next level. It's extremely rare, but that's the next step that he's beating on us.
Well, that's performance excellence.
Yes,
so it cuts across different industries. We are obviously in the healthcare industry, and the highest you can get is nationally level 5. But the Tennessee Center for Performance Excellence is representing the levels that we work with, and level 4 is the highest you can get in the state. So that's what we're in pursuit of. And as Bruce said, it's rare, but we're completing application now, and we feel confident that we'll be able to achieve that.
And then just a few things about COVID. I know the emergency is over, thankfully. Nobody's happier about it than our staff. But some things are permanent. We just nationally, 5 to 10% of nurses left the workforce. They either retired or they moved into a non-patient care area. Nursing schools, there are plenty of applicants, but they don't have enough faculty to gear up for the new students. We instituted a nurse residency program 3 years ago, 2.5 years ago, and we're bringing in about 20 nurses every year. But as quickly as we bring them in and get them up to speed, we're losing sort of our experienced nurses the same way. And this is common, this is national, but it's common in Tennessee. We have seen that starting to see some nurses move back into full-time positions nationally, a little bit less reliance on contract labor. But the contract labor is so terribly expensive. For us, it costs about $40 an hour for a staff nurse. A contract nurse is $100 an hour. So just think of one 12-hour shift. That's $1,200 instead of $480. And we've got 175 nurses on staff, of which about 50 or 55 of them right now are contract labor. That used to be 15 3 years ago. And I say that knowing full well that my daughter is a nurse, an ICU nurse in North Carolina, and always asks me, "Hey, Dad, do you think I should travel?" And I'm like, heck no. Stay where you are. Don't travel. Because it's attractive. I mean, they can make $65 an hour traveling and have a stipend. And for a young person, it's hard to fight against that. The other is, like I said, here's just a highlight. ICU nurses went from 55 to 140. I think Vanderbilt was paying $200 an hour to keep ICU nurses. But now it has migrated back to about $100 an hour in ICU, and ER and med surg about 90 to 95. Respiratory is still way up there at about $100 an hour. So our contract labor costs in 2019 before COVID were $2 million. In 2023, they're going to be almost $9 million, and then next year we're budgeting for them to be $9.7 million. So even though the rate has moderated, the number of vacancies is continuing to rise, even if slightly. So I budgeted a decrease in 2023. It did not materialize, and I don't want to get bit that way again. So we basically assumed it would basically be static for next year. Hospitals nationally, if you read any of the journals, you'll see hospital costs, and whether it's Vanderbilt, HCA, or anybody else, 15% a year costs increased the last 3 years, 15%. So staff, our starting RN pay here at Nashville General went from $24 to $32, so just in the course of 2.5 years. And that's for starting staff, and then obviously people that are more tenured have higher rates of pay. And we've offered incentives for people to stay. We're recruiting new ones and therapists in. We are budgeting a 5% wage increase in this budget for 2024, but we have to meet the market. Sometimes we literally just did an increase for our RNs in the hospital that pay direct patient care in April. Which was not budgeted, but we have to keep staff intact. And we are actively renegotiating our payer contracts with our payers, but 15% increases are just not coming. No disrespect to Blue Cross or United or Humana. No one's offering 15% increases because your costs went up 15%. It's a squeeze that every hospital's suffering. And just as I noted earlier, we did get about $3.5 million from the state this year, 2 different lumps. Every hospital, I think, in the state of Tennessee that takes TennCare receives some of those dollars, but we were informed that it's one time only. Those are ARP dollars, and they will be exhausted before the close of this fiscal year. So this is really sort of my page for the budget. That's the actual and projected on the left for 2023. And then the middle one is the request that we actually sent to the administration back in March and presented. And you can see that it was a request for $60.2 million. Most of those numbers on the revenue side don't change much, and resulted in a total expense of about $141.7 with a small $700,000 operating loss. With the recommendation from the mayor's office at 57.8, we've threaded that into the yellow on the right. And then you can see some changes that we made. We moved our vacancy rates back closer to what they've been running this year. We can't hire people fast enough. And I'm not talking nursing. I'm talking about in support areas. We still have difficulties hiring staff to replace. And so the time to hire is pretty extrapolated for us. And I think most hospitals, probably most businesses these days. So when I moved that vacancy rate, I was able to shave off about $1 million of salary expense without any impact. We did drop our contract labor by about $500,000 projected. We've just got to make that a focus to reduce that expense. And then in supplies and pharmacy, those have regulated. We were seeing double-digit increases the last 2 years. The last 6 months, my supply expense has been closer to a 6% annual increase. So I teased that down a little bit. And we have a third-party company helping us with our 340B discount program for pharmacy, and that allows us to get additional discounts on pharmacy purchases, and we think that that will have about a $300,000 favorable impact on our pharmacy spend this year, or 2024. And then the last one is that other expense. A lot of that other expense each year that I have to build in are those leases that I end up having to incur because we don't have access to capital. Thankfully, we have access to capital. I don't have to leave those major repairs and construction projects in other expenses because I'll be able to draw capital and pay for them. So very much appreciated. And so all in, it looks like about a $139 million expense line for the hospital and a small negative operating margin of about $500,000. So that's just an easy sort of way to look at it. And we've shared this with our budget, with our board over the last couple of weeks, and this update just on Monday of this week.
Is that a small negative?
Yeah, it's a small negative. It's a loss of $500,000. Right here.
Fine, I look for the parentheses.
Yeah, that's not how we do it in fund accounting. So that's, I'll just say, that's our presentation for today, and we are happy to answer questions and
Thank you.
happy to be here.
Thank you. Thank you for that presentation. I'd just like to remind council members, thank you all for being here. A copy of this presentation and all of our hearing questionnaires are available on the Metro Council SharePoint, so you can review that there. We'll open it up for questions at this time. Are there any questions? Councilmember Hurt.
Thank you all so much for being here. I have a few questions. So I know that there was a floor that had been rehabbed in order for COVID purposes. Are you all using that floor for anything now?
Yes, we do. We were able to convince the state to not basically remove all of the finish there. Mm-hmm. So it could only be used for things such as extra office space. It's not suitable for patient care because of the way it's designed. So we were able to, where we didn't have places to put people that needed to spread out, we do have some use there.
So do you still have COVID patients? I mean,
Oh yeah,
yes.
yeah, but we never really, that space actually never really got utilized for overflow, mm-hmm. which is what it was built for the hospitals within the region. Mm-hmm. So it never really got utilized for that because the overflow never occurred.
Okay. The other thing is that, and you kind of touched on it when you were talking about how you were able to save some funds from the COVID. So I'm just wondering if it did reduce or eliminate any shortfalls that you thought you would have, that $7 million that you got from the state in COVID funding.
It was actually about 3.5 this year.
But the $4 million that you got from ARPA. Also, wasn't that federal funding?
Yeah, it comes through the state, but it's technically federal funds that come through the state.
Right.
We did. I mean, we would have been in way worse position if we hadn't gotten that.
Right.
But I'm looking at Director Flannery over there. You know, the reality is that if we get funds in like that in a big bucket, then they don't have to give me subsidy for a month or so. So, I mean, that's commonly the way we do it. So, you know, if we got to the end of the year and we didn't need it, then they'd keep it at Metro.
Okay, and the third thing is that you talked about 340B. I know the state has made some decisions that have impacted 340B, and I'm just wondering, I know it may not necessarily be strongly with you as it relates to HIV and AIDS, but I know for StreetWorks, it really have impacted us. I mean, where we've lost half of our 340B funding, and I was just wondering if you had a similar impact.
It didn't have a significant effect with us, but I do agree with you that it feels short-sighted, and I'm not picking on anyone, but the 340B program and the way TennCare in the state actually utilizes it, because my experience there is through TennCare. Right? And TennCare is operated uniquely, I will just say, here in this state. And they basically don't allow providers to access the discounts because they believe that those discounts should be pointed to the MCOs that manage the TennCare patients. So we're actually paying back money from 3 or 4 years ago because we were what we call a carve-in, which means we are able to get those discounts on Medicaid patients.
Right.
But the state was getting the discounts too, and so now we're having to refund money to massive companies because the state claimed those discounts when we feel like we should have been able to claim them. Can't win that.
Right, I know. Thank you.
Thank you. Councilmember Toombs, you're recognized.
Thank you, Chair, Vice Chair, our Chair. And thank you, Bruce and Dr. Webb for being here. I have several questions. For fiscal year 23, fiscal year 23, how much was the subsidy from the city?
It was 54.04.
And do you anticipate drawing down that entire subsidy?
We've drawn down all but 3.8 of it as of this week. So yeah, we do probably anticipate we'll have to draw it all down unless we get some other magic money at the last.
So looking at your projected budget for fiscal year 24, the repair and maintenance at $4-ish million that you had in there, is there any overlap with that in the 7.3 million?
Not really that one. I would just say most of that one, Council Lady Toombs, is, that's mostly like maintenance contracts, like IT service and service contracts for equipment and so forth. It's less repairs. It's actually maintenance contracts that are required, for imaging equipment, IT equipment and so forth.
Would any of that be expenses that qualify as being able to come out of the 4% fund?
Either the 7.3 capital or the 4%, yes. That's why I highlighted the other expenses on that, because I think that's where I'm going to save it. I'm not going to have to do lease expense on some things that happened to us that were unplanned.
So the 7.3 does include some of those expenses, or it's in addition
I'm anticipating that it will save me about $500,000 operating in 2024, yes, at least.
But there are still some capital expenses beyond the 7.3 that are needed, correct?
I won't have access to the 7.3 until July or sometime after that. And right now, we're in the middle of a $1.2 million IT infrastructure refresh that we had to do under an operating lease agreement because we had to do it.
I think she's asking if there's are there any additional capital needs beyond what
the
7.3 will allow?
The $7 million.
The answer is yes.
Yes, the answer was we had a $21 million, but we knocked it down to 7 because we've never gotten more than $1 million, or $1.5 million, and it was 4%. So yeah, we have about $21 million. So the 7 covers about a third of what we believe is needed.
Those are the most urgent.
Yeah. Yeah.
Okay. And just so that I'm clear, like with this IT repair and some of these other repairs, those are potentially 4% expenses that can be taken out of your operating budget.
It's just the timing is always the issue.
Okay.
That we've already entered into contracts for this company to come in and do the infrastructure refresh at the data center.
Okay.
If I had access to that capital next week or in a month from now, I could kill that lease and not have to pay that $250,000 a year.
Have you ever, after paying for those expenses, because of the timing, submitted a 4% request so that you can get reimbursed?
Not for an operating lease because it's not capital, I guess.
Okay. And your request for the fiscal year 24 subsidy was $60 million?
60.2, yes.
60.2 million. The recommendation from the mayor's office is 57.8. And in your presentation, it showed like a $500,000 deficit?
Yeah.
So how did you reconcile between your ask and what is allocated?
I'm I'm not sure if, are you asking, I don't know what the rationale was for 57.8 versus 60.2. I mean,
And I'll back up. So if you asked for 60.2 and you got 57.8, I would expect in your projected budget to see a $2 or $3 million deficit, but it was 500,000. So that's why I'm saying, how did you work those numbers out?
we spent 2 weeks going through the numbers to find every edge that we reasonably could take from an expense standpoint, because we and our board is charged with bringing a balanced budget forward.
All right, so you have to have a balance. So what kinds of things so you cut some things, right?
Yeah.
Okay, and so what kinds of things did you cut?
We increased our vacancy staff positions by about 15, and that produced almost $1 million of reduced expenses.
So when you say you increase your vacant staff positions, that means you have open positions that you're just going to let them stay open?
We've had a hard time filling open positions. I'm not talking patient care now, non-patient care, support areas like me or billing or something. We have had around 35 vacant positions on average, and we had historically run about 20. So we budgeted 20 because that's where we had historically been. But when we were trying to find a way to balance to the 2.4 shortfall, that was a reasonable place to go in there and make that change.
Okay. Any other areas that you cut? That's 1 million.
Yeah, well, supplies and pharmacy we touched as well, because when we looked at the last 6 months, the rate of price increase had abated a bit. It had been double digits for almost 2 years straight. So I took another look at the last 6 months, and our pharmacy costs are about 8% instead of 12 year over year. And our supply costs were about a little less than 6%. They were 10% last year. So I think reasonably I could back those down to improve the numbers. Let's put it that way.
Any impact on employee pay or proposed COLA and raises?
We did the 5% stayed intact in the budget. We did not make that change. I know Metro has steps and whatever. We only have one, and we budgeted 5%. It did not get touched because I think that's the least we should do.
So if we could, or if it ends up that some of those, some expenses can be 4% expenses are covered by the 7.3 million, you may not actually have a deficit of the 500,000.
Possibly. That's possible, yes. Okay. I mean, we make it work every year, Councilman.
I know.
We have to.
I know. What are unaffiliated legacy charges?
That one is, in our subsidy annually, we're charged about $200,000 a month for the Bordeaux and the Knowles pension and other expenses. Those are charged against our subsidy.
Okay. Those are all my questions, Chair.
Thank you. Councilmember Allen.
Thank you. I want to follow up on that last question. In the budget ordinance, it shows the $7 million somewhere down in line under the surplus capital for y'all and the $57 million surplus payment, but it also shows a fairly large payment for Knowles and a much smaller one for long-term health care. So, I mean, the way I read that's money that's flowing around or that going to y'all. Does that, and this may be a question for Kelly rather than for you.
Question, I'm sorry.
But maybe Mary Jo can answer, or Kristen. Is that a different flow of money, or is that the same flow?
Different money, just because the 2.4 million I speak to is actually, it is taken out of our subsidy every month in the low cap.
Okay.
That we're charged, and it's specifically for Bordeaux and Knowles. One's about 170,000, the other was 30,000 a month. So it's actually taken from us or from our subsidy, and so I think what you're talking about is a different set of money that may go to some other expenses that we are not responsible for.
Gotcha. Okay. It looks like it in that, and Councilmember Hurt may know as well. But
I don't know.
Okay, we're
We
looking.
can get an answer from the plan, from the.
If you'll give us a minute, we'll look it up. We might need to get back to you on that. Yes.
Hey. Oh, good.
You were asking about Knowles and
So it's listed in the budget as a separate item. It shows up, I think it shows up underneath the hospital subsidy, and then you see Knowles and Board of Long-Term Care. It's like 10 million and 2 point something.
yeah, on page 479, I think.
Maybe I just remember seeing in the
I don't
ordinance.
know. I'm saying numbers, but not finding the words.
And I apologize. I think I put my ordinance in my council notebook and I'm
Yeah,
not
I'll
finding
find
it.
it. I'll do a word search and get you the actual page number.
Okay.
But it's a separate line item.
It's a separate item.
Yeah.
That's the main question. Okay, thank you.
Thank you. Any other questions? You're at.
Thank you, Madam Chairman.
Yes.
You give us great confidence with your presentation that you've got a good grip on your numbers and managing it. We're grateful for that.
Thank you.
Because it's always tight. It's always tight. The extra room that you have, we certainly have issues trying to find places for some of our homeless. And I wonder if there'd be any chance of a section being used for homeless, maybe with some of the chronic illnesses. I don't know if that's a fit possibility or if anything has been looked at.
I'm going to point that to him because that's not probably for me. I would love to answer.
Yeah, there are a couple things with that. I guess the first is that the space that somehow there's a perception that we have all of this space, we really don't. The floor that we were talking about was an unfinished floor that was finished out for COVID patients, and it's really not suitable for housing people. All of the
Not for patients.
no, I meant people.
Oh,
I meant people. I'm talking about homeless people.
yeah.
And the other thing is that you engage in a major risk when you start to bring that population into a setting where you have individuals who are sick or who, so it's a security issue, it's a risk issue, and it certainly does require heavy staffing to make sure that those individuals, nothing happens to them. There's a liability there. So it's a whole nother world that you have to engage in. And with a hospital, you typically don't want to try to do both unless you have a facility that is designed specifically for that purpose and staffed specifically for that purpose.
Thank you. And then I know over the past couple of years, there's been some discussion that it's a possibility you're looking for a new facility somewhere. Where are you
There's
on
been a little bit of discussion about that.
any status report on that? And
Yeah.
in part I ask because if we're going to spend a lot of money capital improving your current facility, is that a good expenditure if tomorrow we're going to move somewhere?
Okay, first of all, I would just say that the capital that we're referring to would be used on patient equipment, which is would be transportable anyway. So it's not repairing buildings or walls or anything like that. Secondly, we have been focused on the existing space that we're in since 1998, built in 1973. A feasibility study was done around 2019. We refreshed that in the past year, and it shows pretty overwhelmingly, and according to our board unanimous vote, that it is more economically feasible to look for a new facility, building a new facility, not finding an existing facility, but building a new facility as opposed to trying to renovate that space, which does not belong to the city, first of all. So it would be millions of dollars to bring it up to code and standards going into another rental period or lease period. And so I'll just say this, the proposal that we're putting on the table is one that would not require the city to necessarily fund the building of the hospital. the hospital pays a mortgage, which it would continue to pay. We're looking at private financing to do that. We have interested parties. We have done the feasibility study. We've done the economic impact study. We've done the pro forma for that. And after reviewing the pro forma, we have individuals or firms, reputable firms, that are interested. So after a 30-year lease arrangement of that building, and as you know, you can look at the revenues there, you see hospitals generate revenues, we would expect that there would be expanded volume, expanded revenues, so there should not be any challenges with meeting a monthly mortgage note for certain. But after 30 years, the city would own this particular asset, and it wouldn't go back to a private owner. So that's the essence of what we're talking about with the new facility.
Thank you. It'll be interesting to watch.
Thank you. Councilmember Hurd.
Thank you again, Madam Chair. While I knew that it would not be feasible to house the homeless in the hospital because of the liability and risks, I am wondering about Bordeaux Hospital, because I'm assuming that you're still getting the funds for the beds, and if the building is just there, could it not serve as a temporary facility for housing?
I would have to ask, what do you mean by we're still getting the funds?
I'm saying, don't you all still own, they have ownership of the beds that at the Bordeaux Hospital that the state actually gave to you all some years ago with the contract, that you would receive funding for those?
I don't believe we're the recipient of any funds from Bordeaux beds. Those beds are not operational at this time. I mean, it's a building, and to your point, I think, if that's an area that the city would like to use as a conversion to a homeless shelter, I think that might have some merit to it. It would certainly require that adequate staff be placed there, and that the place is upgraded to being a safe environment.
Right.
So yeah, it wouldn't be a bad idea to pursue. We'd be happy to help in any way we could at the public hospital with the healthcare needs of that population.
Right.
Yeah.
Including mental health?
We are building on our mental health resources. It is something that is very difficult in the market because they're just difficult to locate. So LCSWs, psychiatrists, we do have some, but yeah, we would, that's also a part of our population. Just because they're homeless does not mean that they're not a part of our population. So,
True.
Yes.
And one other thing is that I know that there's a shortage, obviously, for substance abuse disorders facilities, and just wondering if it were any way that we could utilize those that for that purpose. Because I just don't think, having it sit there, buildings deteriorate more when they're not being used. And if we were able to use that to help, because many of those who are homeless do suffer from some of those barriers. I'm just wondering if there were some way that we could address some of those things and utilize the property while it's still available. And I know it was managed by another company. I know you all did not manage it at all.
Yeah, actually, it wouldn't be a problem for us to provide the care and the services to that. It would require additional resources, which would obviously have to come from probably the city.
Right.
But when we're taking care of that population inside of our hospital, obviously that's all covered.
Right, because you have ancillary services that you already can provide that you wouldn't have to build out or try to build capacity to handle.
So there's some economies of scale that could be used to help which is what we also would have been able to do to help with when the Bordeaux place was actually open.
Right.
But yeah, that same opportunity for economies of scale would exist. And, we'd be happy to sit down and have a discussion about how we can play a role in that. In my previous life, ran behavioral health and chemical dependency hospitals, so I do understand how that need is there.
That's really great. Just good to hear.
Okay.
Okay, thank you.
Thank you. Okay, Councilmember Nash.
How many clinics do you now have, satellite clinics, and where are they located?
We have one that has been open now for about 2.5 years that's located in Midtown on Charlotte Avenue, 1919 Charlotte, to be specific. Our second will be opening this summer. It is on Clarksville Highway, Bordeaux, right across from the library. That one will be a more substantial site. It will house primary care, specialty services, urgent care, as well as have a freestanding imaging center. So for that area, it's been considered a healthcare desert. So very viable community, growing community, and I think we're fortunate to be able to get there and have a footprint there, and lots of interest being shown in that right now.
Thank you. Councilmember Allen.
Thank you. You may have addressed this already, but remembering back to capital that we were able to give last year, there was $2.4 million between 4% and something for electronic medical records that came through.
Request.
Gotcha.
Yeah.
Did we? I was thinking that got allocated in a supplemental 4% something or other last year. Is that? The administrator may be able to help me out. Am I remembering this correctly?
There was an amendment to the budget last year, you may recall, on the floor, and it
A lot
was
of amendments.
Yeah, there were. It was for $2 million for electronic health records, I believe, and then subsequently we added an extra $400K in the follow-on 4% paper. So there was $2 million amended, and I was looking. I think it was recurring funding was the source that it came from. So it looks like it came into your baseline for FY23. And I'm looking across you at the sponsor of that amendment, Councilmember Toombs. So she may also remember the $2 million that was amended last year for electronic health records, and then we did the subsequent $400K to make sure we had topped it off for the full requests that you had had.
And I don't know if that's a question, but I know our board just approved our electronic health record contract.
Gotcha.
So the implementation will be starting in the next 30, 45 days.
Okay, great. So we got that one and on to the rest of the list. Okay, thank you. I appreciate that.
Thank you.
Thank you. Thank you all for being here. I do have one question before you go. I want to thank you for your efforts in changing or adjusting the budget to meet the allocation that's proposed in the mayor's budget. It sounds like that won't impact patient care, which is great. Sounds like the capital recommendation of the $7.2 million will help greatly with addressing some of your equipment, long-term equipment repair, replacement, and upgrade needs. Question about the COVID floor. Do you have any plans for it at this point?
It's actually being utilized now. We would not go through necessarily the cost of capital cost of converting that to a patient care area. We believe that might be resources that we could utilize elsewhere. And I do want to just, if I could, just make one additional comment to your question earlier about new facility. We are looking at a 2027 lease ending timeline on the existing arrangement. 1998 would be 30 years, 2027 for that. So that's what prompted our bringing to the board an alternative to the existing space and led to that decision.
Great. Thank you all. We are doing great on time. We've got 2 minutes to spare. So thank you for your presentation today.